My name is Dr. Madeline Mahoney. I'm a PGY3 at Cherokee Nation Family Medicine Residency here in Tahlequah, and I'll be presenting our QI poster, which reviews diabetic distress screeners and its effect on glycemic control. As we know, type 2 diabetes management can be extensive. Emotional burden, self-management fatigue, and lack of perceived support all contribute to what's known as diabetes distress. This isn't simply depression, it's a unique and measurable psychosocial factor that directly impacts adherence and outcomes. Literature has shown us that elevated diabetes distress scores, or DDS, correlate with higher A1C values, highlighting the importance of addressing the goal. Recognizing a gap in how often we screen for and respond to distress in outpatient practice, we set out with a goal to engage patients in intentional, personalized conversations that acknowledge their specific diabetes-related stressors. Our measurable aim was to reduce DDS scores by at least 0.5 points over a 6-month period. The study included patients impaneled to residents Dr. Bergman, Dr. Haas, Dr. Mahoney, and myself, who had a diagnosis of type 2 diabetes and were seen routinely every 3 months. At their baseline appointment, patients were given the DDS-2, a validated 2-item diabetes distress screener. A score of 3 or higher prompted administration of the full DDS-17. Rather than using a standardized template or checklist, physicians conducted open, individualized discussions centering on the patient's responses and lived experience with diabetes. These interactions were rooted in clinical judgment and the strength of the physician-patient relationship. The same patients completed the same screening tools again at their follow-up visit 3 months later. To support these efforts, we incorporated the AIS model as a conceptual framework. This approach includes being aware of diabetes distress, asking about it directly, assessing with a validated tool, and assigning to behavioral health if needed. From there, we advise patients about how distress can impact disease control, assist in developing an achievable action plan, and arrange appropriate follow-up. In terms of results, at the initial encounter, the average GDS2 score was 4.53. At follow-up, that dropped to 3.57, meeting our 0.5 point reduction goal. However, the average A1C remained essentially unchanged, increasing very slightly from 7.31 to 7.33. While we did not see short-term glycemic improvement, the reduction in diabetes distress itself is meaningful. It reflects a positive shift in patient experience and lays the groundwork for better self-management and engagement over time. We hypothesize that with this continued reinforcement and longer follow-up, these emotional and behavioral gains may translate to improved A1C. In summary, this project highlights the value of incorporating brief, targeted distress screening into routine visits. More importantly, it emphasizes the role of empathetic, individualized conversations in improving patient care. While simple in design, this approach was effective in reducing distress and enhancing the therapeutic relationship, both of which are critical in chronic disease management. Thank you, and please feel free to reach out with any questions. Were given the DDS, a validated 2-item in this aspect of care.